telehealth st True to telehealth style, I had some technical difficulties logging in today, so thank you for bearing with me and your patience. It is my honor today to be hosting this important webinar on living well with diabetes education and empowerment training. Before I start, I want to just thank HRSA and the Health and Human Services and the Office for Advancement of Telehealth, for which the funding for these programs are available. The NRTRC really just appreciates the support to be able to provide these sort of trainings. So I'm Nikki Parasho, the program director, and we here at the NRTRC have had the pleasure of working with Trudy Bearden since 2020. Together, we have developed some great tools, including the Critical Access Hospital Telehealth Guide and many online training modules for billing and reimbursement to support rural and frontier health systems in making telehealth work. So Trudy has a really unique passion for taking deep dives into complex regulations like the physician fee schedule or CFRs, and translating them into clear, practical guidance. As one of our colleagues said, Trudy eats final rules for breakfast. So I have to actually kind of agree with that. But it is a true reflection to her commitment in making healthcare policy understandable and actionable. So she really she's helped healthcare teams take on what's on paper and put it into practice in a way that improves care and outcomes. So for more than 2 decades, Trudy has been focused on improving diabetes care, and that passion continues to shape her work, as you will all hear in just a minute. So without further ado, I'm going to hand the mic over to Trudy to take it over. A couple housekeeping items. Any questions and answers or any questions, please put in the Q&A box, and we will answer those towards the end of the webinar. And I'll let Trudy take it from here.
Awesome. Thanks so much, Nikki. And I want to thank the NRTRC for continuing to work with me and letting me fuel my passion for sure. I also want to give a special shout out to Stacy Kashinchuk. I may not be pronouncing her name correctly, but she did a review and provided some feedback on the content of our slides. She's a registered dietitian. She's a licensed dietitian. She has a bunch of other credentials after her name that are very impressive that I had to Google because I wasn't quite sure what they all stood for. But she's incredibly knowledgeable, and she just gave really targeted feedback that was really helpful. You don't always get that type of feedback, so special thanks to her. I beg your patience for about 5 minutes while I just run through really quickly the journey to kind of how we got here, how I got here, how my passion got fueled for diabetes care and also for telehealth. But I am now semi-retired. I'm a physician assistant by training, and I volunteer at the Pocatello Free Clinic, which is one of the few clinics in the nation that has been continuously run for the past 50 years. And we have a certified diabetes care and education specialist, or CDCES, who does our diabetes training. She's also a registered nurse. Her name is Deb, and she has worked closely with a mentee who is a Spanish speaker. And so Ingrid has kind of hung out with Deb while she's doing the training, especially around food and nutrition. And Ingrid has been able to take over parts of the training, and she's usually there elbow by elbow with Deb if needed. And it really presents a model where if you have someone who is a trained staff member and they have supervision and support, that we can think about innovative ways to deliver diabetes education. As you may or may not know, if you've ever been to the doctor or a PA or nurse practitioner, you have a very short office visit. And so if you were to add up like all the time that we see patients, like even if somebody has 4 half-hour visits in a year, that still leaves over 8,759 hours where people with diabetes are on their own managing this really complex disease. And my journey with diabetes started when with my first job out of PA school with Yale Vascular Surgery. I had done surgical rotations with them, and they said, well, how would you like a job? And I said, no, 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 I'm not interested in vascular surgery. No way. I want to do rural family medicine. They said, trust us. You'll see everything that you see in rural family medicine, and they were not wrong. We had on the vascular surgery service, I appreciated kind of the end stage of what happens to people with diabetes. They would have poor circulation in their feet. They would start getting sores and ulcers in their feet. They would go to the podiatrist. The podiatrist would say, you just have poor circulation in your feet. We're going to send you to the vascular surgeon. They'll do a bypass. And so we would do a bypass, and then I would anxiously be by their bedside, kind of feeling the graft for the bypass to make sure it didn't clot off. And then often it did clot off. And then we were doing first an ankle disarticulation, then we were doing a foot amputation, then we were doing a below knee amputation, then we were doing an above knee amputation. And a lot of our patients died because this is a systemic disease. I also, on my floor, I cross-covered the transplant service. So, kidney transplants, who do you think were getting kidney transplants? It was people with diabetes. And as I said, also on the transplant service, we had a lot of people who died as well. And then I started in primary care. I moved from Connecticut to Idaho. And I was the clinical manager. I had a patient panel of about 300 because I was, doing other things. I was the quality coordinator. I was IT specialist. We implemented our EHR. And I got to kind of see like what happens with people with diabetes. And it's just so complex. Back when I was doing primary care, I decided to live one day in the life of a person with diabetes. And I tried to think about what I ate, and I did carb counting. I can tell you right now, I made it to 10 a.m. That's as far as I made it in my day in the life of a person with diabetes. We ran our panel. So every primary care provider usually has a panel of patients ranging from about, I don't know, 1,200 to 3,000. It's a big chunk. And then, who are your people with diabetes? How do you even track them? I remember running a report, and one of our first year residents said, wait a second, I have how many patients with diabetes? I only see 3 of them in clinic. So it was back then, like probably since 2007, I started every year reading the American Diabetes. They call them guidelines then, and they now call them the standards of care. So this diabetes education set of slides / program is based around the American Diabetes recommendations as it pertains to those things that belong in a diabetes education program. I've also been a practice coach, and I've coached hundreds of community health centers, literally from coast to coast. And what do you think we often work on? Diabetes care, diabetes care, diabetes care. Especially community health centers, are always looking at their percent of people with diabetes who have controlled diabetes, or they have uncontrolled diabetes. We often term uncontrolled diabetes as greater than 9% for an A1C. Recognizing that that's not the goal. The goal is like 7, but so many of them hover at about 30% of people with diabetes that have uncontrolled diabetes. And if you look at the statistics for people with diabetes who are referred for diabetes training, it ranges from 5% for Medicare patients being referred for diabetes self-management training, or DSMT, to a little bit of a higher percentage for people with diabetes being sent for diabetes education. And honestly, as a clinician, it wasn't really on my radar to send my patients for diabetes education. We actually had a nutritionist, a registered dietitian, who would see patients, but I didn't know what went on behind those closed doors. As a quality coordinator, I didn't know of our population with diabetes, what percent had been sent for diabetes education, and the American Diabetes Association recommends that all patients at time of diagnosis receive diabetes self-management education and support training, and then annually thereafter for people who are uncontrolled or when things change. So, I have seen some really excellent examples of helping people manage diabetes outside of kind of their visit with their clinician. Harry Riley Clinic in Boise just had an entire team where they did process mapping for when a patient comes into our care, like what are all the things that they need? Like they need diabetes education, they need dental care, they need eye exam, they need their kidneys checked, they need, the list is really, really long. And so they kind of had a flow diagram to make sure that things happened. The Saban Clinic I worked with last year on a ginormous project in LA, and they had a pharmacist-led diabetes clinic, and the pharmacist would say they had a patient with diabetes where the diabetes was off the charts, like just uncontrolled with a really high A1C, and um, they finally said they kept upping her insulin, no change, no change. And then the pharmacist, she met with the pharmacist in the diabetes clinic, which was their version of diabetes education. And there was a little plastic cap that the patient was not taking off of her pen, so she was not actually getting the insulin. So, let's just kind of sally forth. I will tell you that I was in a family medicine residency. I was the clinical manager of the Idaho State University Family Medicine residency. Because I was the continuity provider, because I didn't graduate every year to the graduate residents, I had a lot of complex patients, and a lot of them were people with diabetes. A lot a lot of my patients had my phone number because they were that fragile. So all that to say that diabetes is really, really complex. We have so much more to do. And there's a lot of help that we should be providing people with diabetes. And I want the mantra for today to be something is better than nothing. Something is better than nothing. And that pertains to diabetes education, but it also applies to lifestyle changes. So I'm going to give you a little sampling of what we've put together. So I had this idea that, and I shared this with Jolene and Nikki, and they were 100% on board, that if we could put together a set of slides that contained the American Diabetes Standards of Care as it pertains to lifestyle changes and those things that people with diabetes need help with. So eating healthy, particularly, becoming more physically active, learning more about their diabetes, and taking their medications as directed, that if we could kind of make this more available to more people, to train, if you're in a healthcare organization, to train staff, to supervise those staff, and continue to improve your diabetes education program, we could kind of extend this support for people with diabetes who deal with this complex uh, constellation of things that are happening to your body, especially if in the setting of uncontrolled diabetes. So without further ado, let's go ahead and get started and kind of jump into, well, kind of like what exactly are we? Let's see if I can navigate my way properly here. Just give me a second. It's just a set of steps to make sure I do this correctly. Okay, so you should see the slide. So we really had to be careful about how we named this program, because diabetes self-management education and support, well, I'll show you in a minute, kind of when you say that DSMES, people have a vision of what their training is. So this is a diabetes education program. We're just going to keep the terminology easy peasy, and we're not going to cover people with gestational diabetes. So this does not cover pregnant individuals, and we're not going to cover type 1 diabetes. That's very complex because you're always dealing with insulin. And Medicare, Medicaid, and other insurance plans will mostly cover Medicare. It is a Medicare benefit, a benefit to have diabetes self-management training. But what about people who don't have insurance? So you can't refer them for diabetes education because they may not be able to pay out of pocket. So it's not affordable. It might be too far away. Um, it could be inconvenient times. We offer diabetes training when, weekdays from 8 to 5. Like that doesn't always work for everyone. Um, Telehealth is an amazing solution, of course. I mean, even if you are just talking to somebody on a phone, as long as we know they're paying attention and not multitasking and, making dinner and going grocery shopping. But there's also navigating the healthcare system, and they know us. So if they come to our healthcare organization, they know our reception staff, they know our MAs and our LPNs, they know us, they know the routine when they come to see us. If we refer them to a diabetes education center, they have to get themselves to that place. They have to, it's new people. You have to establish that rapport. And I will tell you, as we said, kind of tales from the field is that unless you develop some sort of a relationship with people, it's hard to move forward with them with making lifestyle changes or for them to even share things with you. Um, I don't think a lot of people know that patients have a lot of fear about coming to an office visit. They're afraid what we're going to tell them. We're going to scold them. We're going to blame them, shame them, or judge them. And it really takes kind of building that relationship. And they kind of already have a relationship at a healthcare organization. They kind of know us to a certain degree. So there's a bunch of kind of caveats and disclaimers and acknowledgments and purpose statements, and you need this additional information. So this diabetes education program and content offers a flexible option for healthcare and other organizations to deliver diabetes education, provided you have adequately trained and supervised staff. I think if I were to be doing this, again, as a clinical manager, I would probably find a nurse or an MA who is passionate about this. And I would go through these slides, make sure they understood the information. And then for their first few visits, I'd probably sit in the room with them and I'd like do my chart notes and whatnot. And then afterwards, listen with half an ear and then give them some feedback, because feedback is key to building expertise. And that's how we learn and grow. There's a reason one of my favorite books is called Thanks for the Feedback. So, I want to, as Nikki said, just a shout out for the funding and support for this work. I'm so grateful for this. And then we're really all about feedback. So if people are using the Living Well with Diabetes Education program and they find an error, or they say, hey, I found this whiz bang resource, can you add it? Or it would be really helpful if you reorganize the information, any feedback or corrections. We're always very open to the feedback. This is an important disclaimer, of course, that the views, opinions, and content of this webinar are mine and Nikki and Jolene, of course. And I want to be very, very clear. This diabetes education program content is not a substitute for an accredited diabetes self-management education and support program that is taught by a credentialed educator. That is the preferred option. So if a patient can afford it, they have insurance coverage, by all means, that is it. Remember how I said what my mantra was for today? Something's better than nothing. So if somebody can't attend one of those DSMES programs, then what? Like we just say, oh, you're out of luck? No, now we have a backup. And DSMES programs are reimbursed by most state Medicaid agencies. And if the patient has insurance coverage, then sure, that's what we much prefer. And I know reimbursement and I know primary care like inside and out. And it is, I can't really find a clear pathway for reimbursement. if you are having trained and supervised staff that are not licensed or credentialed, deliver this information. Maybe you will find it creatively. You can have a credentialed licensed person who does the majority of the education, but then you also kind of have someone who does a little bit or supports, and you might be able to find a way to reimbursement. But we really didn't feel it was fair to say like, oh, well, you might be able to. I think that's kind of dangling a carrot that is not quite fair. So DSMT is a covered Medicare benefit, as I mentioned, and I worked for a couple of years with a diabetes education center. I would tell them, so they were kind of trying to optimize their efficiency. And I told them many, many times, like every person, January 1, for every person with diabetes that has Medicare kind of has like a countdown on their forehead of they start with 2 hours. And then you have 4 half-hour sessions in the year before they use their calendar year, before they use that benefit. And it's a use it or lose it. Like you don't carry it through to the next year. So, shame on us if we're not taking advantage of that opportunity to connect our patients with diabetes with education. And DSMT, the codes, the specific billing codes for DSMT and MNT have been approved by CMS to be delivered by telehealth for like, I don't know, 20, 25 years. So diabetes self-management, education, and support. And I feel as though I'm beating a dead horse with this a little bit, but I want to be sure that the people who are credentialed and are delivering these accredited programs know that we're not trying to pull ourselves off as having the type of rigor and structure that a DSMES program has. I've seen the backside of an accredited DSMES program, and there's a lot to it. There's a lot of paperwork, there's a lot of documentation, there are reports that you have to submit to maintain your accreditation. This is not that. But it is an amazing program if you can connect your patient with that. So also, I wouldn't feel comfortable as a clinician having just a trained staff person provide education around insulin use or dosage. So we have not included that content here for patient safety reasons. And also the same is true for continuous glucose monitors. It's someone who's super duper well trained, maybe, but I would not feel comfortable with that as part of this content. And then I do think that it's not that hard to figure out how to do just a finger stick blood glucose and train patients how to do that, and how to kind of remember what the steps are if you have to put a sticky note on the monitor, because if you have low blood glucose, you can't even remember how to use your blood glucose monitor. The content is designed to be practical, accessible, and streamlined, and really focusing on key points and information. And we've tried to keep out extra information, or what one of my friends, Dr. Asaf Batan, calls TBU, or true but useless information. My fear in having Stacy review the materials, is her feedback going to be relevant and on target, or is she going to give me all these things to say, well, you need to add this and you need to add that? She didn't. She was like a really good editor. Most of the information has been crafted to approximately an 8th grade reading level. You can't do a PowerPoint presentation as education. The idea is that the educator will be familiar with the information and might use the PowerPoint slides as a kind of to remember what the standards of care are. I've also envisioned that maybe you could print these slides and put them in you can put them in those sheets, plastic sheets in a 3-ring binder, and you can kind of flip through them and sit side by side with the patient. And for some of the slides that have a lot of information that might be helpful for patients, you could make multiple copies of the slide and just do it as a handout for the patient. Is how I've kind of envisioned if I were to, I actually hope to pilot this myself. our diabetes educator at the free clinic is retiring sadly in November. And I maybe I'll take over diabetes education and pilot these slides. We'll see. So we want the slides to be easy for people to modify. So you can do group classes, you can do one-on-one settings, or you can do virtual settings. So you can do this by telehealth. It's easy to hide the slides that you may not want to cover. Um, I also have learned from Deb, I've asked her very closely, I'm like, how are you so good at what you do? And part of her approach is that she thanks people for attending, first of all, which I think is really awesome because people are busy, they've got busy lives, they've got all kinds of things going on. And she asks them, what would you like to learn? And she starts there. And I think it's a really good place to start building rapport. The content in the slides is based on the ADCES. ADCES stands for the Association of Diabetes Care and Education Specialists, which diabetes CDCESs, Certified Diabetes Care and Education Specialists, are a group of credentialed individuals who do a lot of diabetes education. But the ADCES 7 is the structure that is used by diabetes self-management education and support programs. They have their website has a lot of resources in multiple languages, and they cover basically 7 topics with kind of another topic that is sprinkled throughout. So there's healthy eating, so much around healthy eating. I was reminded while I was putting these slides together that 50% of the calories consumed in the United States come from ultra processed foods. Like, I knew it was a lot, but wow. So something is better than nothing. Even if you can identify for a patient, like what are some of the ultra processed foods that you're using and what's a smart swap? Like what can we trade out that's not ultra processed. Being active is just amazing. So exercise or physical activity, taking medications as prescribed. There's so much that gets in the way of taking medications as prescribed. We have primary non-adherence where people can't get to the pharmacy to get their medications, or they don't fill them for whatever reason, cost, inconvenience, etc. And then secondary non-adherence. Which is you don't take them as directed. I don't know about all of you on the call, but even just remembering to take a multivitamin a day is hard for people. And imagine you have medications that are dosed twice a day, or you have to take ones with food, and then you have to, maybe you have to take one at bedtime. Like sometimes there's 4 times a day that you have to take a medication. Like how in the world does a normal human being who has a real life going on, like manage that? It's really, really challenging, but there are some strategies that we can help patients with. Monitoring, there's so much to monitor: your blood glucose, your A1C, all of the tests that you need to get. Reducing the risk of complications. Like I just saw the end result of complications over and over and over again in a vascular surgery and on the transplant service, and was very, very sad. And then healthy coping with diabetes and emotional well-being. There is a term called diabetes distress that is real. I had one of my patients who was in the emergency department every week, and Idaho Medicaid said, look, this is your patient. You need to keep her out of the emergency department because this is unnecessary care. It's expensive. What are you going to do? And so my solution was that I had a standing appointment with this patient. I saw her every Tuesday during my lunch hour. And I could bill for the visit, but it was a lot less than going to the emergency department. And I billed like a level 2 office visit. It was kind of just a check-in with her. And I was able to keep her out of the emergency department, but she just needed reassurance. You're okay. Let's go over all of your medications. She would talk to me about her symptoms. I would let her know what she needed to worry about, not to worry about. Just the kind of the specter of diabetes hanging over your head, and everybody talks to you about complications, and you need to eat right, you need to do this, and you need to do that. It is it really, really takes its toll on people, and people who have anxiety or have toxic stress and they have cortisol levels that are elevated. It is difficult to control diabetes in the setting of high cortisol levels as well. And then problem solving to find solutions and take action. Like what happens when you're sick? What happens when you travel? Like how are you going to, keep your insulin if you're on a plane? Those kinds of things. And then kind of the underlying, like I said, kind of the one that's trickled all the way through is kind of understanding the disease process and treatment options. We have some specific terminology. You just heard me use the term primary non-adherence and secondary non-adherence. Actually, the American Diabetes Association says that you should not be using that type of language because it kind of harks back to paternalistic medication terminology. So a couple things to think about kind of before you launch the diabetes education program, and we will have a companion document with some of this laid out. So you kind of need to do some preparation. So you need to communicate with staff, let them know that this is a service that is now going to be available for staff, for patients with diabetes. Here's how we're going to do it. Hopefully you have a team that you kind of get together, an implementation team. Things you need to sort out are documentation. When I worked with the Diabetes Education Center, they had never gone and talked to the providers of the patients, that they were seeing in the Diabetes Education Center. And so I connected them and I got them in a room. I'm like, what's working, what's not working? And all the providers said, your reports are terrible. They're really too long. Like they would post them to the Health Information Exchange and the providers would pull them down. They're like, I can't read all that. And one doc said, well, at the very bottom, here's what my findings were. Here's what the plan is. Here's when I'm following up. Those are the things that I like. And so they completely changed their documentation that they sent back to the people who referred patients. But if you're doing it in a healthcare organization, like what documentation do the providers want to see? Do you have a template that makes it really, really easy? Like I would design, if I were a clinical manager again, I would design my own template that went along with the ADCES 7. And, here's what we talked about. We didn't talk about this other thing. These are what the goals are. Here's what the SMART goals are. The patient would like to start walking once a day for 20 minutes with their dog after work. So, how are you going to document? And if you have that documentation and you write a note, so if your trained staff member learns how to write a note that makes sense and then has the plan in there, the goals in there, are you going to route that note for co-signature by the person who's supervising? Or are you going to ask for the primary care provider to sign off on it? I would recommend the primary care person. Primary care provider, primary care person. Look at me trying to talk too fast. So, will educators have access to the electronic health record? Maybe they don't. How are you then going to do documentation? And what other, is it just like a couple of bullet points? So you need to get documentation sorted out and often creating quick texts or dot phrases. Like I remember saying the same thing over and over and over again for nutrition advice. Like, I don't know, something like hamburger meat is the #1 source of saturated fat in the American diet, blah, 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 cut down your, hamburger meat or something like that. And, dot ham would insert the whole paragraph of what I would ordinarily say on a regular basis to my patients. Backup plan for educators. So they will run into questions and scenarios and things that they aren't going to know how to handle. And they need to, like, who do they go to? So if something is kind of urgent, like what do? They need to have backup reinforcement for sure. The workflow considerations, I strongly recommend taking an opt-out approach. So during pre-visit planning, as you're looking at who's due for what, if you have a patient with diabetes and they haven't had diabetes education in the past year, they get referred for diabetes education unless the provider says, don't do it. So a bunch of workflow considerations. They need to have HIPAA privacy and security training if they're not part of your organization and haven't already done that. Quality improvement, there's so much there. Like, can you run a report? I know at our free clinic, we can run a report of all of our people with diabetes with A1Cs greater than 9, but we don't have a structured data field for whether they did or did not receive diabetes education. So, it's a little annoying that we can't do that. We're working on it, and we'll probably find a way around it. And quality assurance, that supervision part is what's really important to make sure that the education is delivered completely, consistently the same. Like, you always have the same. Each person with diabetes has the same high quality educational experience, is what I'm saying. The other thing is feedback. You can't grow or improve unless you get feedback. So how are you going to survey patients about how their experience it was with their education? You do not want to send them a survey or send them a link for a survey. They're right there. Like, let's just get feedback right there. And then, yes, you might notice that I have a little bit of a hang up about that. And then reimbursement, is there a pathway to reimbursement that you can come up with? I haven't been able to find one that is clear cut. Here's kind of an example. So you have a person who's newly diagnosed or they have poorly controlled diabetes. Is an accredited diabetes self-management education and support program available? If not, refer to our internal Living Well diabetes education program. So then there's a section with an orientation for educators. It's a little bit of kind of early heads up training. The overarching goals of the program, really kind of making healthy food choices, achieving and maintaining modest weight loss. 3 to 7% is what the American Diabetes Association recommends if somebody's overweight or obese. But let's just be real. What does 3% to 7% mean? You need to know the patient's weight, and you need to know how to calculate and multiply times 0.03 or 0.07 to get the range of weight loss. You have to have sensitivity to discussing weight loss. If the patient says, leave me alone about weight, that is totally understandable. I had a patient who Idaho Medicaid had assigned to me. And the first thing she said to me was, I've seen so many providers and they just tell me I need to lose weight, lose weight, lose weight. I can't afford to eat healthy. Don't talk to me about my weight. I said, fine, we won't. So then I talked about other things. A lot of them had to do with health-related social needs. And about 3 months later, she said, Trudy, I'm ready to talk about trying to lose some weight. It can be a touchy topic. Engaging in recommended levels of physical activity. Yeah, we all make those New Year's resolutions, and then we expect our people with diabetes to follow the recommended levels of physical activity. Like, how do you find a way to make that work for people? And then getting their recommended follow-up screenings, tests, and other care. So one of the ones that I'm very passionate about is diabetic eye exams, for example. So if we catch diabetic retinopathy early, we can prevent 90% of diabetes related blindness, which, diabetes retinopathy is the #1 reason for eyesight problems and blindness in people with diabetes. So I can't see chat or the Q&A. So Nikki, I'm just going to pause to see if I'm not paying attention to anything that I should be paying attention to, or if there are any questions that are relevant now rather than waiting. So I'm just going to pause for a second and check in with you.
Okay, great. Yeah, there is one question in the chat, and it asks, what do you think about this program being modified or individualized to support DSMES program delivery? Would you recommend a new DSMES program utilize these slides as a starting point to designing their program?
Really good question. So it depends. Are we talking capital DSMES or are we talking lowercase DSMES? If it's capital DSMES, you would have to go to the ADCES, Association of Certified Diabetes, ACDs. Oh, my acronyms. Association of Certified Diabetes Care Education Specialists. If you were going to be doing capital DSMES, you would have to go to the very formal content, and you would have to have a credentialed individual like a registered uh, dietitian, nutritionist, or a licensed dietitian. Some states require that you are licensed, like Stacy is an RD, so she's a registered dietitian, which is a national kind of licensure accreditation. And an LD is a licensed dietitian. That means you're also licensed in the state. So you would have to have people who are credentialed to deliver capital DSMES. And you would have to have an accredited program, and getting that accreditation is very rigorous. But if you're going to do a small DSMES, so if you're going to do a diabetes self-management education and support program, yes, you could use these slides. These slides, the guidance for around what the guidance for all of those 7 that are included in these slides, most of it is actually taken from the American Diabetes Association. They publish their guidelines or standards of care like every December. And a lot of the recommendations have like so much evidence, and they have so many experts on their panel when they kind of review and come out with the standards of care every year, that it is a reliable way to kind of say, well, what should I be including in my diabetes education? If that does not answer your question, chat additionals and say, well, she talked around and she didn't quite answer it, because I'm happy to take that on if I haven't quite answered it the right way.
Great. Thanks, Judy. And that's it for now.
Yeah. Okay. And each diabetes educator has their own resources that work best for them. So Deb at our free clinic, she has this like tri-fold thing that folds out, has a lot of text on it, but it has those kinds of things that she often turns to and looks at and goes over with the patient. She also has a set of plastic cup measures. So when she has conversations with patients about, I should call them participants, not patients, when she's talking about serving sizes, because we're like, oh, well, you need to pay attention to serving sizes. I don't know about you guys, but serving sizes are confusing. Like, not everything comes like it's grams or it's ounces or it's a cup or it's 12 chips, or, serving sizes are like all over the place. And a lot of them are in grams and, or milligrams. And, I didn't bring my food scale. I don't know. So you have to kind of have the resources that work for you and your participants, and you'll find your way. For the educators, if you're a provider and you're going to refer a patient, your patient better than anyone else, and what they need to focus on. And it's possible that the patient has said like, yeah, I know you've got me on this really complicated medication regimen, and I can't remember to take, I really try my best, but like I cannot take my statin at night. And so rather than just saying, oh, well, you need to go see our diabetes educator, sending that person to the diabetes educator and saying, please focus on how to take medications as directed, is really helpful, so that you can hone in on what it is that the patient really needs and what the provider would really, really like the participant to focus on. So telehealth is essential. And so this is actually from the American Diabetes Association. And they say that telehealth and other virtual tools can expand access to diabetes self-management education. Notice that's small DSMES, by overcoming geographic and transportation barriers, especially for people living in under-resourced areas or those with disabilities. Like, it's, we always make our patients come to us, come to us, come to us. When I was doing primary care, to get around that on my way home from work, I would often stop in and see my patients in their homes. And I had a patient, for example, who's, sorry, this is a bit of a tangent. She had non-healing ulcers on her feet. And I'm like, why can't I, why is nothing working to help her heal these sores on her feet? And I went to visit her, and part of that was because she had very low calcium, and she could only eat the soft calcium caps, and insurance didn't cover that. So I would go buy her those. I would stop in where she lived, and I would give her kind of soft caps for calcium. And she had deep shag carpet, and she had dogs, and the dogs were gnawing on raw, kind of stinky bones, and then they were coming over and licking her bare feet. And uh yeah, so you never are quite sure what's going on in people's homes. And so telehealth makes it easier for people to participate in diabetes education, and you can sometimes see their home, or they can hold up, like, I'm supposed to be taking this medication, they can hold it up for you to see. It can be really, really helpful. Also from the American Diabetes Association, OBVI, is to make sure to anticipate and address challenges such as internet access, affordability, digital literacy, and the capacity of both patients and healthcare systems to integrate the virtual care into existing services. And I don't know if Jolene can put a plug in for the resources that she has been working on around digital literacy. But also, the diabetes highlights strong evidence that supports the use of telehealth and other virtual options like video visits, mobile apps, web portals, text messaging, which can be really, really helpful. As long as it's not, sometimes it sounds like a really great idea, but when you get down to how to actually do it, each patient with different EHRs, getting access to the portal, et cetera. But digital coaching is also really, really helpful. And I've really thought about this program for a diabetes educator, that maybe we should be switching this, or kind of in parentheses calling this kind of coaching as well. Like, is there a role for in between visits to have a diabetes educator say, hey, if you can text securely to say, hey, I know you had a goal of walking. How's that going? Or something like that. So diabetes actually, the American Diabetes Association actually says that outcomes that are comparable to or even better than those seen with traditional in-person care. So telehealth and digital tools can outperform just traditional, we make them come to see us, model that we have. So you can do audio visual, you can do video only, or you can do text. The text thing is tough because we bump into HIPAA, and it kind of gets in the way. I have had patients sign something. I don't know if it's actually approved by the Office for Civil Rights for a HIPAA for HIPAA compliance. But they would before they would text me, they would say, I accept. It gave them verbiage, and I said, I accept that this is not a private and secure way to communicate with my primary care provider. The video conferencing, you can look at the food the participant eats. Like, so if you're talking to them about ultra processed food and they're like, I really cannot make heads or tails of this. Like, I know you've told me a bazillion times how to kind of alert me to ultra processed foods. What is this? Like, what is this? And they can hold it up for you. So it's really helpful. You have to get an initial assessment. One of my favorite sayings is from Yogi Berra: if you don't know where you're going, you'll wind up someplace else. And the same is true for diabetes education. You need to know, like, where are we starting from, and what are we going to work on, and how are we going to improve, and how are we going to know that any of the changes are an improvement. So start with an initial assessment, and that can be a form. We have an example of a form that you can modify. And you have to partner with the participant, focus on 1 to 3 areas that they're interested on working on. Use whatever you can to help make sense of things. Prep before the sessions. So there's nothing more annoying when you're a patient to come in for an office visit, and the provider spends like the whole time looking at your EHR chart, trying to figure out like, who are you and what's going on with you. And so it's really important to prep before the session. So if possible, if the educator has access to the patient chart, they can look like, when was their last dental visit? What was their last A1C? Is their blood pressure controlled? Do we know how their kidneys are doing? Are they due for their diabetic eye exam? Do I need to see about getting that scheduled for them? For all you know, in a community health center, if the educator says, oh, you're due for an eye exam, often community health centers have diabetic retinopathy screening right there on site. Um, Review the problem list, like what's in their problem list, what's in their medication list. Review their social history, where you can find smoking status, because if any person with diabetes is smoking or using tobacco/nicotine products, it's a good discussion to assess where they are on the motivational interviewing scale. Are they pre-contemplative? Are they contemplative? Are they ready to quit smoking? And evidence shows that the more times you ask a person about their readiness for quitting smoking or tobacco, the more likely they are to kind of get to the point of, yeah, okay, fine, like you bugged me enough, I'll do it. Are they using alcohol? What's their living situation? Are they unhoused? I was on a project in California where we had to deal with a lot of people who are unhoused because, housing is a premium there. And if we had if we had a participant who was on insulin, for example, and they were unhoused, how did they refrigerate their insulin? Like, so things that we need to know. It's good to know, how long have you had diabetes? Have you participated in diabetes education before? How did it go? What went well? What didn't go well? What should I make sure I do differently? Just a side note about vaccinations. I didn't go into this. If you're going to discuss vaccinations, then you should go to the CDC vaccine recommendations. So setting goals, like what's their A1C? Where do they want to get to? Where should they get to? So if they have an A1C of 10, they're like, yeah, maybe I want to get it to 9, and say, oh, let's set a goal with heart. Let's get it from 10 to 7, and it may take 6 months. So what is their blood glucose level? What's the time and range? What are their lipids, blood pressure, weight, physical activity, taking medication? So there's a lot of goal setting that can go on. And so by the end of the program, participants should have, at a minimum, a plan for how and when to check blood glucose. And you have to check in with the provider too. So some providers say, I have a patient with type 2 diabetes, their A1C is 7%. I don't want them to have the additional stress of having to check their blood glucose. They're doing fine. This is the message I want for them. Some providers have even said, I don't want my patient to have a blood glucose monitor. Personally, that's kind of not where I would head, but you have to respect what their primary care provider says, and how to document the values. So some monitors, if you do your finger stick, but you don't have the app, the Bluetooth app open on your uh, phone, it won't capture the value for you. I don't know who designs things like that, but so how are you going to log or document your values? How are you going to do meal planning that works for people? Like, does somebody have time to, if they have carrots, to peel them, cut them up, and put them in the fridge? Like, is that going to work for them? Can they have this, doing meal planning is tough. Can you use, the note in your iPhone to say, here's what I'm going to do for, each day of the week. On Fridays, I'm going to have the same thing. On Wednesdays, I'll have, whole wheat pasta with sauce or something like that. Meal planning is something that the American Diabetes Association and pretty much everyone else says is really, really important. And how are you going to increase physical activity to work towards the recommendations? Physical activity is just so important for improving insulin sensitivity and all kinds of other things. Physical activity and exercise is not a weight loss strategy. It's a weight maintenance strategy, but how are you going to work towards the recommendations in a way that works for you? I know one person with diabetes would her children had singing lessons. So when she dropped her kids off for singing lessons, it was too far to drive home. So while she sat there, she would walk and she would walk and she would be on her phone, but at least she was walking. So, whatever works. How are you going to remember to take your medications, and how are you going to make sure that you get your medications refilled? Like sometimes someone can be on like a lot of medications. One of my patients with diabetes was on 20 medications. She saw a lot of specialists, and every time she had a symptom, specialists would like prescribe another medication. How do you remember to take 20 medications? I used a pharmacy for her that would load a med box for her, but like how, like it's people need help. How do you schedule for your regular health checkup? So we ask people like, what's your A1C? Oh, it's 9. Well, you should get that checked every 3 months. Well, when was that 9%? And when is it due? So rather than telling people you need to get that checked in 3 months, you should say you should get your next A1C on or around October 15th. And then ways to deal with stress, including getting good sleep. So I'm just doing a time check. So we're an hour in. And I do want to kind of show you what the slides look like. And that's actually starting on the next slide. So I'm going to spend a few minutes going over kind of what the slides look like. Jillian may have already mentioned to you when you will have access to these slides. There are, hold on to your seat, 154 of them or so. There are about 150 slides, and we've only kind of covered 31. So we're on slide 31, and I've hit a couple of the slides so that I don't bore you too much. A lot of talking, a lot of content. I know. I hope you're eating your lunch and that it's not ultra processed food. So how do you even start off? And then what you're not seeing is that in the kind of the bottom of the slide, there's a place for notes. So the note that you can't see that's here is the note to the educator. You will find your own words, but this is a place to start. Introduce yourself, set a friendly tone, and explain how the session will run. Yeah, like the reality is, like if I were a diabetes educator, I would not start with welcome to living with diabetes, a diabetes education training. But you have to start somewhere. And I'm not quite sure like the level of comfort or extroversion that educators will come to this training with. So just kind of a place to start. I do believe that saying thank you for taking the time to attend the session is important. And that recognizing that they are the expert of them and we need to learn about them. When I've worked with convening and getting feedback from patient panels, what I hear from patients a lot is everybody treats us like we don't know anything. We are the expert of us, and they can learn from us. And I think that's a really important point, because if you're listening to patients, that's what they will tell you. And then I'll help fill in some things related to diabetes that you want or need to know. Like you lead, they need to lead. And then together we'll develop ideas and plans to help you live well with diabetes. So then we move to the content. This is the table of contents. And remember, I told you about the seven helpful behaviors, self-care behaviors. And then there's that 8th one. I will end up taking out these hyperlinks, but for now, these hyperlinks would help me if I wanted to bounce to one of these topics. So there's a laundry list of shared diabetes education goals. So the note to the educator for this, for example, is it's a long list. So just see what makes sense or what doesn't make sense. The excellent feedback from Stacy was to turn this into an active learning by using it as an opportunity for participants to share their goals rather than kind of list all of these. This would be kind of a bit of a waste of somebody's time, but you have to find your way. And as I said, I just don't know how people are coming into this. Each slide in the upper right-hand corner, as you can see, lets you know whether the content is more for the participant or more for the educator. And you'll see those. I had a really simple design for the slides. And then I conferred with a friend of mine who is really good at designing kind of interesting looking slides. But I think what I'm going to do is keep it really simple. The formatting is really simple so that people can change these up as they like. So I actually changed the content. So we kind of start from where having a basic understanding of diabetes. And I did not know this for many years, but a lot of people feel as though they have diabetes because they did something wrong. And I think it's really important to make sure that people don't think that it's something they did. So it's not your fault and you're not alone. I mean, there are so many people right now with diabetes. And for a lot of people, type 2 diabetes can be, you can kind of put diabetes into remission. The key to that is weight loss, but you never ever cure diabetes. Um, just kind of getting clear on the terminology. So as a clinician, I always call it blood glucose and I'm like stuck on blood glucose, blood glucose, blood glucose. That's not what participants call it. They call it my sugar. A lot of people say I have sugar diabetes. I measure my sugar. And we can't get stuck on like, oh, well, it's not sugar, it's glucose, which is a form of sugar. Like it's just like it doesn't make sense to get stuck on that. So whatever they want to call it, as long as I understand what they're talking about it, fine by me. Um, just kind of some basic, so like people still hang on to the insulin dependent diabetes. I was reading a book the other day, Adaptability by Dr. Herman Poncer, and he still used those terms, insulin dependent diabetes and juvenile onset diabetes. This is a really simple graphic that I put together. This is your body turns food into sugar in the form of glucose, then your cells need and use glucose for energy, but your body also needs insulin to move that glucose into your cells. Diabetes is caused when your body doesn't properly use it or make insulin. If there isn't enough insulin to move glucose into your cells, then you develop high glucose levels, which leads to diabetes and all of the complications. Let's see. This is kind of a summary, what I'd like to do. And I have used some of the materials from the American Diabetes Association. They give you permission to use their slides as long as you don't modify the content. So healthy eating, so there's a whole section on healthy eating. I'm not going to go over it. But what I do want to show you is that this is a slide that is specific to the educator, if you see in that upper right-hand corner. And for the educator, BMI is not perfect, but we don't currently have instruments that can make physiologic measurements that come close to the BMI, which is kind of easy to calculate as well. So it's easy to obtain, it's easy to calculate. There's a lot of problems with it, but it's what we have right now. So let's not throw the BMI out with the bathwater. But if you have a person and their BMI is 30, and they're like, well, I agree. Yes, I'd like to lose, some weight. If you say that 3 to 7% of weight loss is helpful, I want to lose 5%. Like, how do you calculate that from the BMI? And how do you make sense of it? So that's something that I think all of the educators should have an idea how to go about that. We have some tables about what are high sodium foods. I'm skipping a lot of slides now, so I'm jumping around. This is a really helpful table from the American Diabetes Association. Like, what are the behaviors to encourage What about carb counting? So carb counting used to be a really big deal, and people did it a lot. It, drives people a little crazy, like, oh my gosh, like I don't like math and you want me to carb count. So if people are not on insulin, this may not be something that you need to worry about. You may have heard about glycemic index, and while it is true that people who eat a diet with low in foods that are high have a high glycemic index, um, it's the American Diabetes Association really is focusing not on carbs, not on protein, not on fats, foods. They're focusing on foods. What do people eat? And how can we help them make smart swaps? So if they're eating something that is high in, sorry, my mind's already thinking about the next thing I want to say. If somebody's eating a diet that's high in saturated fat, for example, how can we switch it? Like if you're having eating hamburgers, how can we switch that to a salmon fillet sandwich or something like that? So glycemic index is important, and you pretty much have to think that a food that is high in fiber is going to not be a high glycemic index food, and a high glycemic index food makes your blood glucose rise high after the meal and quickly after the meal. Foods that have a lower glycemic index often have fiber, and so there's kind of this delay in blood glucose levels. There's just a ton of information in these slides. The diabetes plate method, the American Diabetes Association really recommends the plate method, which is kind of a nice visual. You don't have to remember glycemic index. You don't have to count carbs. Let's see. So being active is really important. There are several slides on being physically active, but as an educator, you need to find out like what is going to work for the participant to actually improve their physical activity. And how do you set goals? How do you set SMART goals? Here's an example. Medications, what gets in the way. So we want to make sure that we identify what gets in the way and eliminate or help them kind of get around that. So if somebody can't get to the pharmacy, for example, do we put them on mail order medications? So kind of know what your options are. We have some slides on kind of what are some of the tips for taking your medications as prescribed. There's monitoring, a whole section on monitoring, a whole section on apps. So, what are the apps that are helpful? My sugar is actually pretty okay. I actually have that app. My Fitness Pal is also great for people tracking calories, which honestly, if you're going to want to lose weight, you have to kind of reduce your intake of calories, and you can do that by counting calories and then restricting the number of calories. You can do that by intermittent fasting, or you can decide that a particular food is high calorie, and so you eliminate it. And that's basically kind of the top 3 ways that you cut down calories. But calorie counting for many people is a pathway to suffering. So you have to be careful with whom you make that recommendation. Here's another example of a diabetes, the ADA graphic. Chronic kidney disease. I had one patient, actually the same one who had the non-healing lesions on her feet, and I had been caring for her for many years, and her kidney function was decreasing. And I would say, if you don't take care of your diabetes, your kidneys are just going to get worse. And honestly, that doesn't work. It's not a motivator. People don't get motivated to change their behaviors by telling them all the bad stuff that's going to happen to them, but I did it nonetheless, I will say. And she finally was, at a moderate to severe loss of kidney function. And I said, you are going to be at kidney failure and looking at dialysis in the next 6 months or so. And she got so mad at me, she fired me as her primary care provider and went to somebody else in our practice, which she didn't like that person either. So she came back to me, but that's a bit of a tangent. So I think I'm going to pause here. Just going to do a little more. We do have a little more information on body mass index, healthy coping with diabetes and emotional well-being. The American Diabetes Association has some very strong recommendations. So screen for diabetes distress at least annually. So that's significant negative psychological reactions related to emotional burdens and worries specific to an individual's experience in having to manage this demanding chronic condition. So, I don't know if the educator should be doing those screenings. We often have MAs do the PHQ-9 or the PHQ-2 and then the PHQ-9, and they screen for diabetes. There's the Beck Anxiety Index, and we have our MAs do that. So, a well-trained educator might be able to do some of the screening for depression or anxiety, or even do ACE screening, so screening for adverse childhood experiences, which the score for those screens can be an indicator if somebody has toxic stress, and toxic stress leads to high levels of cortisol and poor diabetes control. So depression, like we should be screening people annually for depression, and refer for behavioral health interventions if indicated. The provider should be looking at disordered eating behavior, cognitive capacity and impairment, and sleep health. We have a slide about dealing with stress. I read all those, and I think if I were really stressed out, I'm not sure that reading a book would help me, but those are some things. Box breathing is a really good thing to train your participants on. There's actually evidence this slows down the vagus nerve and helps kind of self-soothe us. We have some resources as well. And I think with that, Jolene and Nikki, I'm going to stop sharing. It is a lot. I'm not sure how many people are still attending and awake.
Great. Trudy, everybody is awake. I am sure of it. That was great. A lot of really good information and resources. We have one question in the Q&A chat that says many need to relearn how to prepare meals. Is there a specific resource available to address diet, recipes, and meal planning?
I agree that people need to relearn how to prepare meals. And other than holding kind of semi-cooking classes, I just don't know how to do the whole preparing meals portion. So at our clinic, when I was at the family medicine residency, we did diabetes group visits. Usually those are really, really hard to launch and maintain for a variety of reasons. We hold them in the evenings. People don't, just like one more thing to do. But I think finding out kind of what their baseline knowledge is a place to start. Of course, like some people really just don't even know how to steam broccoli. It's just the reality. And there are some recommendations to know what their history is with their family. Did they grow up in a culture of preparing meals and eating meals together? I will look for a resource around that, but I'm not aware that there is kind of training people to prepare meals. But when we were doing our group visits, my supervising physician, who is also our medical director, Dr. Dan Jones, he was very passionate about diabetes because his wife had type 1 diabetes. And we would, maybe he will show up for diabetes group visits, we would feed them. And we would feed them with a recipe that his wife had prepared. Like it might be like a crock pot with a lentil stew or something really healthy like that. And we would give them uh, the recipe card and talk about how to do the prep. But that's incredibly labor intensive. I don't know how to do meal prep training without it being something that is labor intensive. I'm open to any ideas. I will look for any type of resource for meal prep. But I mean, you have to get the right foods. You have to have the utensils. You have to have the space. You have to have refrigeration. You have to kind of know what you're doing as well. Open to any thoughts anyone else might have.
Trudy, if you want to open it up, Enid Knight has a question. She has her hand raised. Do you,
Yeah, sure.
okay, so Jolene, if you could unmute Enid. Okay, great, thanks.
Hi, can you hear me?
Yes.
Wonderful. I just need to say that this is wonderful. This type of coaching is so needed, and where I am, I provide this. One of the things I wanted to say is the cultural foods are have to really be considered because people don't want to lose their identity, and that's one of the things. So I work with that a lot. Saying, well, you can eat this, but here's the thing: if you look at a Korean background or uh, uh, a Latino background or Hispanic background, you're going to get a lot of carbs on that plate. You're going to get it. And my uncle is one of them. You're not going to get him to take away his tostones. No way, no how. But to say that you can enjoy, but it doesn't have to be in the mouth. And that's one of the things, the coaching for me, to get people to understand that you can enjoy, but you have to limit. And I just wanted to say those things. This is really fascinating. I love it. And I'm glad I'm a part of this today.
That was really, really helpful. Thank you. And I love how you said you don't want them to lose their identity. And that's really, really true. And I actually, this might make you chuckle a little bit. I actually had feedback from a participant in a diabetes education program. She was Hispanic, and she said, and part of the education program was to go to the grocery store with participants, which I thought was pretty cool. But the educator was showing her like tofu. You should be eating tofu. Later, the participant said, "There is no way, no how that I will eat tofu." Yeah, exactly right. Exactly right. I will strengthen that language, Enid, because of you, because it is a really good point.
Thank you.
Thank you.
Any other questions out there? And if not, I'm gonna take this time to close and thank you all for attending, and thank Trudy so much for your work and passion on this very important topic. As a reminder, these slides are available to you. They will be emailed to you following this session. They will also be on our website, and the video, this was recorded. So if you want to share this with colleagues or if you want to share this with anybody, you can find it on the NRTRC webpage. And yes, if you have any questions, please reach out to us, info@nrtrc.org, and we'll give you guys 8 minutes back to your Thursday.
Thank you so much. Thank you so much for your time today.